Hello all, today we are going to talk about the topic intercostal drainage. So in this we are going to drain the fluid, air or blood from the pleural space, pleural space through intercostal spaces. What is pleural space? In our lung there is a two layer. One is visceral pleura, another one is parietal pleura. In between these two there is a space. And this is called a pleural space. So the fluid from there is drained towards the intercostal spaces. That is called intercostal drainage. For whom we are doing the intercostal drainage? So the indications: the person who have pneumothorax, air in between the air in the pleural space, or hemothorax, blood in the pleural space, empyema, or a malignant pleural effusion, or the person who having pleuro disease. So pleuro disease means person pleura is becoming hardened. That is called a pleuro disease. So for this we are doing the sclerotherapy. Sometimes other than fluid, air, blood, chyle may be there. Chyle means white fluid. So it is formed in the small intestine during digestion. In this the content of the lymph and the fat are there. So these fluid also accumulate in this pleural space. So for those who are all doing this, then come to the contraindications. If there is a severe pleural adhesion, which means there is a attachment, strong attachment to the pleural to pleura, then we don't do this intercostal drainage procedure. Or any coagulopathy, the person who having any type of coagulopathy, then we don't do this intercostal drainage. Under diaphragmatic hernia, if there is any protrusion in the diaphragm, then we don't do this procedure. Let's go into the procedure. First, patient preparation. We have to explain the procedure to the client, and we have to obtain the written consent from the authorities. It may be patient caretaker or any parent out there. Then we should mark the site on the patient chest, where we are going to do the intercostal drainage. That site we should mark, and we should monitor the O2 and supplement O2. O2 saturation and supplement O2. The site of insertion maximum in fifth intercostal space, in the mid axillary line, or in the second intercostal space, it is in the mid clavicular line. This is a major site of insertion. For this intercostal drainage we have a triangle of safety. In that triangle of safety we can do this intercostal drainage anywhere. Anywhere in this triangle. So I'm going to show the triangle. This is what about the triangle. So in between these two spaces, we can notice. So this is the triangle of safety. In this we can do intercostal drainage anywhere. This triangle has border. So that border is base of axilla. This side lateral edge of the pectoralis major, and this side latissimus dorsi, lateral edge of latissimus dorsi, and below in the fifth intercostal space. So this triangle is a triangle of safety. Here we can do intercostal drainage. And patient should be in a three position. That is the person may be in sitting position, or a lateral decubitus position. Lateral decubitus means side lie. The patient should be in side lie, or according to the patient condition we can provide the position. And we have the pleural drainage system. In this we have components, that is chest tube, okay, and a connecting tube, and a closed drainage system. Okay, by using these we can perform the drainage. Okay, in this chest tube we have a variety. Okay, thoracostomy chest tube, trocar chest tube, malcot chest tube, guide wire type chest drain, like this. Like that we have many type of the tubes. The chest tube is inserted in various type of method. Okay, and everything is comes under the thoracostomy. Okay, by the thoracostomy procedure, the chest tube are inserted. Okay, according to the condition, we should choose the chest tube. Okay, if the pneumothorax, we should choose this type of sizes. Okay, for emphysema, for pleural disease, for hemothorax. So this is all about the operative tube thoracostomy, and this is guide wire tube thoracostomy, and this is a trocar tube thoracostomy. Okay, if there is a fluid, okay, we should insert the tube posterior and inferior, which means towards the base. Okay, if there is air, okay, then we should place the tube anterior and superior, which means towards the apex. Okay, we should place. And some of the physiological aspects, physical aspects are there. Okay, that is a distal end of the drainage tube. Okay, that is always 2 centimeter below the water. Okay, and the collection of the chamber, okay, collecting chamber is always 100 centimeter below the chest. Okay, below chest. Okay, large diameter of the collection is 20 centimeter diameter, which means if the chamber has 10 centimeter radius, that is the biggest diameter. Okay, more than this we should not use. And we have one bottle drainage system, one bottle chest drainage system, as well as two bottle chest drainage system, three bottle, and the collected drainage from the bottle is sent to a box, and the collected drainage should be disposable. Okay, that system is called disposable chest drainage system. Okay, so it should be sterile. Okay, then only it can be disposable. And we also have the mobile chest drains. Okay, so it will helpful for the reduce hospital stay. Okay, so the patient have not needed to stay in the hospital. Okay, for that we can use the hemorrhage valve and a mini chest drain. Okay, these like mobile chest drains also we are using. Okay, once we place the chest tube, okay, then when to remove it. Okay, so removal is depend on the indications. Okay, in chest x-ray the lungs should be expanded fully. Okay, after that we can remove the chest tube. Okay, so this is for the pneumothorax patient. Or the pleural drainage, if there is a fluid, pleural drainage is less than 100 ml. Okay, less than 100 ml per 24 hours, then we can remove the chest tube. So the chest tube removal procedure should be explained to the patient, and during the peak inspiration the chest tube is removed in one quick movement. Okay, okay, what may be the complication of this procedure? Okay, it may produce the injury to the neurovascular bundle. Okay, or injury to the lung parenchyma, or injury to the diaphragm. Okay, or injury to the heart or major vessels. Okay, and it lead to the massive bleeding, or it may produce any hematoma. Okay, or subcutaneous emphysema, like these other complications are there. Okay, so during insertion we can use the imaging technique, so that we can prevent the injury to the other part. Okay, by using the imaging we can, is the tube is placed correctly or not correctly, we can identify. Okay, so during insertion we should not use the substantial force. Okay, just x-ray or just CT should be available at the time of insertion. Okay, and also during insertion we should disconnect the ventilator. Okay, so if the ventilator is disconnected, then the lung penetration is avoided. If once the strain is done, again we are inserting, then we should reposition it. Okay, we should not use the same spot. So best is we are using the fresh insertion. Okay, on the same spot we should not use the pushing or pulling anything. Okay, choose new insertion. There is a bubbling, then the air enters from the atmosphere. Okay, so there is a air leak. Okay, if there is bubbling, there is a air leak. Okay, if there is a bubbling, then the clamping is not there. Okay, clamping means the tube is attached with that spot. Okay, that is not happen here. Clamping is not there. Okay, after that we should take the patient care. Okay, that is we should encourage the deep breathe. Okay, and we should give the adequate pain relief after this procedure, and we should encourage the movement. Okay, and also we should guide for the water level. Okay, and we should not avoid milk. Okay, we should avoid the milk and clamping. Okay, and we can also perform the thoracotomy if there is a blood loss more than 1500 ml. Okay, and the drainage collection is more than 300 ml. Okay, per hour. Okay, so it continues for 2 to 4 hours, then we can perform the thoracotomy. Okay, not a thoracostomy, thoracotomy we can perform. Okay, okay guys, in this video we just discussed about the intercostal drainage. Okay guys, thanks for watching. Tata, bye bye.